A very warm welcome to this presentation about understanding trauma and PTSD. My name is Sadaf Akhtar. I'm the lead therapist and coach at Wellbeing Services based in Birmingham, UK. The objectives of this presentation are to firstly define trauma. We'll also explore types of traumatic events that give rise to the trauma response, PTSD risk factors, common risk factors, and theoretical frameworks that attempt to explain the development of PTSD. We'll also explore symptoms of acute and chronic trauma, including the PTSD diagnostic criteria according to the DSM. And lastly, I'll outline some key elements of effective healing modalities. So to begin with, what is trauma? In this presentation, I define it as a state of psychobiological shock and associated distress that typically occurs in response to unexpected or sudden threatening or harmful events. It's a definition that's increasingly applied. However, there is variability in the way trauma is understood. So if we look at the Diagnostical Statistical Manual, which is published by the American Psychological Association, they quite specifically define trauma as exposure to actual or threatened death, serious injury, or sexual violence. So the DSM very much emphasize life-threatening or extremely violent events. To my mind, this is problematic due to a number of reasons. Primarily, that traumatic shock and associated distress can, of course, occur in response to varying degrees of threat or harm. If we look at the work of Robert Scare, for example, who was presented with whiplash patients. So these are patients that had experienced 10-mile-per-hour car accidents, and they developed post-traumatic stress disorder despite being exposed to seemingly minor events. When he examined this further, he did discover that there was a history of chronic stress, trauma, and other physical or mental health difficulties. Nevertheless, on the face of it, the event type was not extremely life-threatening or violent. Nevertheless, the symptoms of PTSD developed. Also, if we look at the work of Dr. Hammer of the German New Medical School, or German New Medicine even, so his primary hypothesis was, or not even hypothesis, so he was investigating the role of trauma in causing physical and mental health conditions, and what he discovered was that all of his patients had experienced trauma. Interestingly, the trauma events were varied, so it wasn't just extremely violent events, it was different degrees of perceived threat or harm. And so for this reason, and also generally empirical research tends to find that the key characteristics of trauma entail shock. Shock can be manifest in different ways, most commonly as numbness. Distress, commonly again, this can present as fear, helplessness, disgust. There's an element of suddenness or unexpectedness to traumatic shock in contrast to general stress. There's of course that perceived threat or harm, and it's subjective in that there's variability in the way people respond to different events, and we'll explore some more regarding individual differences in later slides. And so for these reasons, I think it's more inclusive to focus more in terms of effects rather than event types. So, what are the different types of events that may give rise to the trauma response? Again, there's variability. However, some examples include sexual or physical violence, such as child abuse, physical abuse, maybe domestic violence or trafficking, natural disasters such as earthquakes, floods, wildfires, or tornadoes. There may be medical trauma, such as waking up during surgery or a diagnosis shock. Emotional and psychological abuse, which can include bullying, humiliation, manipulation, grooming, harassment, and so on. There may be relational trauma, such as the death of a loved one, a separation or betrayal. Or material loss, such as losing a home, wealth, or sudden unemployment. So these are just some examples of events that may give rise to the trauma response. Survey studies suggest that trauma is a common experience. So a survey carried out in America and Europe in 2015 found that over 70% had experienced at least one traumatic event in their lifetime, while in the UK the longitudinal twin study in 2019 found that approximately 30% had been exposed to trauma by the age of 18. And so trauma is a common experience. However, again, remember that there's variability in the trauma response, and it's a subjective response that's influenced by individual factors. And some of these factors, some of the risk factors for developing long-term symptoms of trauma or PTSD include the following. So the absence of coping strategies, which can include compassionate support. If there's a history of prior trauma or chronic stress, there's a greater likelihood of developing chronic symptoms. Pre-existing physical or mental health issues. The severity of event, the more severe the event, the greater the likelihood of developing symptoms, according to research studies. And of course, recurring trauma. So if it's chronic recurring trauma, there's a greater likelihood of developing long-term symptoms. So what are some of the immediate trauma effects? And these typically last weeks or days to weeks, sometimes 2 to 4 weeks, keeping in mind that the symptom response may vary from person to person. However, what studies have found is that the following appear to be common reactions to traumatic stress. So emotional responses typically include, of course, numbness, confusion, staring into space, disbelief, sadness, fear, panic, irritability, anger, guilt, shame, or despair. Cognitive effects may include obsessive thinking, nightmares, memory problems, or difficulty focusing or making decisions. Physical effects commonly include stress, nausea, dizziness, poor appetite, pain, or fatigue. And common behavioral effects may be avoidance or withdrawal. It's important to remember that these symptoms are a normal reaction to experiencing a highly stressful situation. And again, generally they tend to subside 2 to 4 weeks later. Generally, if these symptoms persist for over a month, it may indicate PTSD development. Being mindful, however, there may be delayed onset. So sometimes trauma symptoms may not necessarily appear straight away. In some cases, there may be a delay of 6 to 12 months. And there's various reasons for why this may be. In some situations, it may be that the person experiences relatively mild symptoms, which may be adequately managed by self-care, or they may be exposed to a trigger or further stress later on. It's not clear what the precise mechanisms are, but in some cases, trauma symptoms can either manifest later or tend to get more severe later on. So we're going to explore how the DSM categorize PTSD in later slides. However, before we do that, just to make you aware of the limitations, diagnosis limitations. So there's lots of criticisms leveled at the process of diagnosis in mental health settings. And one of them is, of course, we can see from the outset the focus on just specific violent events as characterizing trauma, which of course, overlooks the experiences of many other people who experience trauma symptoms but haven't been exposed to very violent events. Other criticisms that have been leveled at the DSM include the sense of not people's experiences not being fully captured. Of course, the DSM is very much a quantitative measure, so it's not designed to explore people's experiences in depth. And then there's also the assumed abnormality. So people feeling that when they receive a diagnosis, including PTSD or other types of diagnosis, that they're seen as having some kind of inherent problem that is generally not addressable, and this causes stigmatization, where people may discriminate or mistreat them in some way. Furthermore, another problem for some people is that the process necessarily entails a specific type of treatment approach. So in a clinical setting or psychiatric setting, it may be that a person is diagnosed and given prescription medicines or drugs or hospitalized, which for some people is not a suitable way to address trauma. Generally, to my understanding, it's not necessarily the case that if you're diagnosed with a particular condition that you'll necessarily be given prescription medicines, but in some facilities maybe the approach is quite very much like that, and so consequently some people choose to address their symptoms without receiving any formal diagnosis. So just to sort of be aware of that. Having said that, the DSM, despite its limitations, the symptom categories, such as what's on the screen at the moment, these key components, are based on research. So these are research studies that have been carried out into people's experiences, again with of course the understanding of trauma as being an event, a particular event type or exposure to threatened death, serious injury and so on. Nevertheless, there are commonalities and symptoms that people experience, but again mindful that there would of course be variations. So some people may experience mild symptoms that don't meet the criteria, whilst others meet all of them. In any event, let's explore the understanding of PTSD. So how does a DSM define PTSD? How do they categorize and diagnose it? So there's 5 key components, or 6 key components even. And the first of these is that there must be exposure to actual or threatened death, serious injury, or sexual violence. The second key component is that there needs to be 1 or more intrusion symptoms, and we're going to go over the details of these shortly. Thirdly, 1 or more avoidance symptoms, 2 or more negative alterations in cognitions and mood, 2 or more marked alterations in arousal and reactivity. And the disturbance must last for more than a month and cause significant distress or disability or functional impairment that's not attributable to other factors. So these components are what is required for a diagnosis of PTSD. However, there may be the occurrence of dissociative symptoms, and so the final diagnosis may be PTSD with dissociative symptoms, or subtype, and we'll explore again the key symptoms for this as well in later slides. So to begin with, the first key component is exposure to actual or threatened death, serious injury, or sexual violence. And this can be either directly experienced, such as a car accident, physical assault, natural disaster. It may be witnessing the trauma, witnessing a violent attack, a severe car accident, or someone being killed, for example. It may be learning about a trauma, or learning that a close family member or close friend has experienced trauma involving actual or threatened death, serious injury, or sexual violence, for example. Or it may be repeated or extreme exposure to aversive details of the trauma. So police or paramedics repeatedly encountering human remains, for example. So the second key component is that there must be one or more intrusion symptoms. And so intrusion symptoms can be either intrusive memories, so vivid sights, sounds, smells, or other sensory details about the trauma. There may be flashbacks, which is intrusive memories, but they tend to occur as though the person is reliving the event. There may be nightmares or distressing dreams about the event. Or there may be anxiety, depression, or other emotional distress in response to reminders of the trauma. Or bodily reactions such as increased heart rate, sweating, or muscle tension when exposed to reminders of the event. The next key component, after intrusion symptoms is avoidance. So one or more of the following needs to be present. So it may be avoidance of images, or so internal avoidance of images or emotions such as sadness, anger, or fear, or avoidance of physical sensations. Avoidance may also be with substances, work, or excessive exercise. Or there may be external avoidance, so avoidance of people, places, animals, objects, or any other external stimuli that reminds the person of the event or events. The fourth key component is negative alterations in cognitions and mood, and two or more of the following symptoms need to be prevalent. So it's either partial or complete amnesia of the event or events. There may be unrealistic views of oneself, others, or the world. There may be distorted blame of self or others. Emotional distress such as chronic fear, anger, or guilt. There may be withdrawal from daily activities such as social activities, work, or recreational. Or there may be feeling emotionally disconnected or detached from others. And lastly, difficulty experiencing positive emotions such as joy, love, or satisfaction. So the next key component is marked alterations in arousal and reactivity, and two or more of the following symptoms need to be present. So firstly, there may be a sense of being overly alert for potential threats, even in safe situations. An exaggerated response to sudden noises, movements, or other stimuli. Irritability or angry outbursts that are often disproportionate to the situation. There may be self-harming behaviours such as substance abuse, reckless driving, or unsafe sexual behaviours. There may be difficulty focusing or maintaining attention, or difficulty sleeping due to the distress from trauma related thoughts or feelings. And so the prior 5 components are what are required for a PTSD diagnosis. However, there may also be presentation of dissociative symptoms. And there can be 2 types of dissociative symptoms. Firstly, depersonalization, a sense of detachment or feeling disconnected from one's own thoughts, feelings, sensations, or actions. People may describe, for example, feeling numb, robotic, or as floating outside of their body, or as things seeming surreal. Or there may be derealization, which is a sense of disconnection from the external world. People may describe it feeling strange, unreal, or distorted, that the environment is dreamlike or even distant. And so, to summarize, according to the DSM-5, the diagnosis for a PTSD diagnosis, components A to E must be present. So, exposure to actual or threatened death or extreme violence, intrusion symptoms, avoidance, negative alterations in cognitions and mood, marked alterations in arousal and reactivity. And of course, these must cause significant disturbance for more than a month, and possibly impairment, so disability as well. There may also be the presentation of dissociative symptoms, and so the final diagnosis may be PTSD with dissociative subtype. I forgot to mention at the beginning of this slide that, of course, if you're struggling with any trauma symptoms and want to get diagnosed, this presentation is only for informational purposes. It's not in any way intended for anyone to diagnose themselves with a condition, and that if that be the case, then it's always advisable to see a GP or a psychiatrist. Okay, so we've explored a little bit about the understanding or definition of trauma, its acute and long-term effects, including the risk factors, and we're going to go on shortly to outline some other impacts of unaddressed trauma. However, I just want to make you aware that some of you will be familiar with the term complex PTSD, so CPTSD. So just to highlight that it's not actually, the DSM don't make the distinction between CPTSD and PTSD. This is done by the ICD-11, which is the International Classification of Diseases. So the ICD-11, their definition of PTSD includes components of, for example, re-experiencing avoidance, perceptions of threat. However, affective dysregulation, negative self-concept, and interpersonal difficulties is included in the CPTS diagnosis. The last time I checked anyway. And so they make that distinction, and as far as I understand it, the distinction is made on the basis that PTSD is believed to arise from single event traumas or trauma that occurs over a short period of time, while CPTSD tends to manifest or occur in response to recurring chronic trauma. So that's just something to be aware of. I will also add actually that the DSM do, I think, quite comprehensively incorporate a lot of these symptoms into their diagnostic process. Okay, so how else can trauma impact people? What are the other trauma-related conditions? So research studies have found that in addition to the acute and chronic trauma-related responses, including PTSD that I've already mentioned, other effects can include the development of depression, there's suicide risk, anxiety, substance misuse, personality disorders, eating disorders, or obsessive compulsive disorder. Physically, studies suggest that people may experience chronic pain, chronic fatigue syndrome, diabetes, cancer, dwarfism, gastrointestinal problems, cardiovascular diseases, ulcers, autoimmune disorders, and chronic sleep disturbances. So what causes trauma and PTSD? So what we know already about how acute trauma manifests is that there's this perceived threat or harm, and in the case of trauma, it's a perceived, it's more intense. It's a perceived threat or harm which activates the autonomic nervous system, in particular the sympathetic branch of the ANS, and this basically results in the fight or flight response. So it energizes the body basically to attack and run away from the predator. However, as is typically the case with trauma, people often experience or go into a state of shock and freeze. So the way that this may manifest is numbness. They may not be able to move, speak. They may stare into space, feeling tense, cold, paralyzed. They may even collapse to the ground and faint. Again, like fight or flight, it's also a protective mechanism that aids coping with intense distress and survival. However, how do people go from this acute response to developing long-term symptoms such as PTSD? So there are different theoretical frameworks that attempt to explain the development of PTSD. Here I've included three that are based on empirical research, and they complement each other quite well actually. So the first one is emotional processing theory. So from an EPT perspective, PTSD develops as a result of how people make sense of the experience, the meaning-making process, and the extent to which they suppress and avoid the emotional distress. So a trauma event occurs, for example, there's the manifestation, occurrence of symptoms of shock, fear, guilt, helplessness. And then a person may formulate certain meanings as a result of the event. For example, not feeling safe, or that it's my fault, or that I'm powerless, for example. Concurrently, there may be active suppression or avoidance of the emotional distress. And this essentially maintains a fear pattern that is upheld by the belief. So you've got the initial experience that occurs, and then certain beliefs are formulated. There's the suppression of the distress as well, and that maintains the fear. And then this fear pattern is generalized to non-threatening situations, causing PTSD. From a neuroscience point of view, traumatic shock overwhelms the brain. Consequently, trauma memories are stored as sensory fragments, so vivid pictures, smells, or sounds. The traumatic shock inhibits the prefrontal cortex, so it basically impairs a person's ability to logically process what happened and provide a coherent narrative of events. Often people say that, I don't remember parts of what happened, or don't remember the memory entirely, and that's partly because of the way that trauma memories are processed. And then what happens as a result is that the person continually reacts to fragments and other reminders of what happened, which maintains trauma symptoms. German New Medicine actually incorporates the prior two frameworks. However, they more specifically argue that it's repeated trauma, remembering that trauma from a GNM point of view is not necessarily exposure to extremely violent events. It's a subjective experience, and it can result, from seemingly minor or varying degrees of threat or harm. So it's repeated traumatic shocks that cause a left and right brain imbalance. So in order for the brain to work in a normal functioning way, both the left and right brain hemispheres need to work in sync with each other. So we know that the left brain, for example, is concerned with logical, analytical, and language processing, whilst the right brain tends to be more emotional, concerned with creativity. And so, in order for the brain to work optimally, both hemispheres need to work in sync with each other. However, when traumatic shock impacts the brain, it causes an imbalance. It causes these so-called disordered symptoms that are PTSD. However, from a GNM perspective, it's actually an innate and coping response, a survival response. The symptoms manifest due to the underlying distress. So remembering that trauma research, it's an ongoing area, and that whilst there's a lot that we've discovered regarding the process of trauma, there's still more that we need to learn about. So here's just really an introduction to some of the key frameworks that are grounded in empirical research, which if you choose to, you can learn about. Okay, so what are the key elements of effective trauma healing? Trauma experiences are, they're unique to each person. The degree, the level of the symptom severity, for example, the types of events experienced, the extent to which a person struggles with other mental or physical health conditions, including a variety of other factors, will all sort of determine the best approach to healing. Sometimes that requires taking prescription medicines. In some cases, symptoms can be so severe that a person requires hospitalization. However, the process of trauma healing itself, I've outlined here some key components that have been promoted by therapists, including myself, and generally it's advisable to take a more integrated approach. And so I'm going to present these key components, not in any particular order, again, because what's applied and when it's applied will very much depend on individual factors. However, some of the key components include, of course, compassionate, tailored support. So working with a therapist that is sympathetic and understanding and particularly invested in helping you to heal and address the problem is essential. And also tailored, meaning, applying the techniques that work best for you at that time. And sometimes that may require, making a referral to other services if necessary. Another key component of effective trauma therapy is the implementation of self-regulation techniques. So here I'm referring to self-care, but of course these are generally incorporated into any therapeutic process as well. So you want to be applying self-care techniques regularly, remembering that with unaddressed trauma, it's maintaining a fear pattern, and so it's important to try and teach the body, the mind and body, that it's safe. And so how can you do this? There's various different types of methods you can apply. So some of them include self-care EFT, there's yoga, increasingly yoga therapy is being applied. I wouldn't apply that on its own just to heal trauma. I think it should be an adjunct to other methods. Nevertheless, that is a really good self-care routine. Maybe gratitude practices, journaling, breath works, mindfulness, walking in nature. There's so many different types of techniques that you can apply. Many of these are included if you go to my blog on my website at www.wellco.co. There's lots of information there about different types of techniques, but you want to sort of find a technique that works best and then apply it regularly, so daily if possible. Also, an important element is addressing any current stresses or stress symptoms. So sometimes this simply requires a practical approach, so just implementing a practical strategy, or accessing environmental resources, that can be sufficient. Other times, again, self-regulation techniques such as EFT are really good for alleviating general stress as well. And so sort of devising a plan to try and address any sort of general stress or stressors is a good idea prior to sort of working on any historical trauma. And of course, developing awareness of the trauma and conflicts. Often people are very much, they know what the trauma is. In other cases, such as recurring trauma or chronic trauma, there may be partial or complete amnesia. And so when a personal history form is carried out, again, it needs to be tailored to the individual needs. And then, of course, processing trauma. So how do you process trauma? And this is, of course, involving altering or transforming negative cognitions, emotions, and sensations. There's various different methods. Some of the ones that I've included are more sort of evidence-based. So exposure therapy, for example, is a common treatment approach for trauma. There's emotional freedom techniques. Again, this is also an evidence-based technique that's proven to treat PTSD and other mental health conditions. Cognitive restructuring, or CBT, which is included in EFT and exposure therapy. And then there's the EMDR, and this is also it's often specifically applied to treat trauma, and somatic therapy. So again, I think an integrated approach would probably work quite well. And what is the end result of successful therapeutic or successful therapy? Firstly, being able to narrate this trauma story without distress, so being able to talk about it without feeling distress, and of course an improvement to mental, just general well-being, including mental well-being, physical well-being, social well-being. And so these are, some of the key outcomes you would experience as a result of trauma therapy. And again, it can vary from person to person, but generally these are some of the key elements that are for effective trauma healing. So I hope you found this presentation useful. If you have any questions about this topic or any other queries, then do feel free to get in touch. Take care.